So, good morning, all. I think we all agree that in the management of uveitis, reaching a diagnosis is challenging, and because of the varied presentation and the potential mimickers. So, when we see a case of uveitis, we make a provisional diagnosis based on the presentation, the pattern recognition, the ancillary tests and investigations, and start with either the specific therapy or an empirical therapy. And during the course of empirical therapy, if the response is good, we are confirmed of the diagnosis. This is in the case of ocular tuberculosis. Sometimes during the course of empirical therapy, uh, surprises happen, and we have to promptly recognize it and correct our treatment to prevent vision-threatening complications. So today in this instruction course, we have a few challenging cases which will be presented with a focused discussion on how to and practical tips, how to treat them and manage them. And also we have our guest faculty, the uveitis expert, Dr. Anuradha ma'am, who will be giving a keynote address, giving us practical tips in tackle such situations. So first we have Dr. Divya, who is going to talk on Weak-Age syndrome, spectrum, inflammation and beyond. Dr. Divya is an expert vitreoretinal surgeon at Girdhar Eye Institute, Kochi, and she has won many prestigious awards. So over to you, Dr. Divya.
A warm good morning, everyone. Uveitic harida. So it is a multi-system disease manifesting as bilateral granulomatous panuveitis, and it is a disease caused by T-cell mediated autoimmune response targeting melanocyte-rich tissues. So it is primarily or precisely mostly a choroidal stromal inflammatory disorder. As we have shared antigen pools in the choroids and mostly uniform distribution of melanin associated antigen, the disease is always bilateral. So this is the classical presentation. The patient will be coming to you with bilateral sudden onset vision loss. There will be multiple serous retinal detachment multifocal. There can be optic disc edema or hyperemia and multiple yellowish white subretinal lesions or precipitates. So OCT can be a key diagnostic factor. There will be multilobular subretinal fluid. Enhanced depth imaging will show a huge choroidal thickness. Sometimes even with the enhanced depth imaging, the precision of the choroidal thickening can be challenging because of its huge thickness. And there can be subretinal septae, RPE undulations, and whenever there is a subretinal fluid during acute inflammation, the photoreceptors can be split along the myoids junction. The photoreceptors split between this, it is called as the Ballard or the bacillary layer detachment. And dye tests are diagnostic. There will be hypoperfused areas corresponding to the choroidal infiltration. There will be multiple pinpoint leaks and subretinal fluid, subretinal pooling, and hot disc or the early leg disc leak, what is called as hot disc, which is characteristic. And as the harida, it is a primary stromal choroidal disorder. The hypoperfused granulomas can be clearly delineated in ICG more than that of an FA. So even though variable, the prognosis of the weak age is generally fair, provided there is early initiation of high dose of immunosuppression, adequate duration of immunosuppression, and absence of recurrent inflammation. So this is the same patient. The patient had a counting finger 1 at presentation, and after that with 6 months of immunosuppression, the patient is still sustaining with 6/9 vision. So there is light at the end of the tunnel. So keeping this in mind, what is if there is an atypical weak age presentation, presenting a 52-year-old female, acute painless vision loss isolated to left eye, right eye was completely asymptomatic with a visual acuity of 6.6, left eye had a visual acuity of 560. There was no significant medical history or past history pertaining to the disease. And the fundus examination, right eye was within normal limits, but left eye show multiple serous detachment and multiple yellowish white subretinal precipitates, and OCT show multifocal serous detachment with Ballard sign, and EDI showing a huge choroidal thickness, and the fundus fluorescein angiography showing pinpoint leak and the pooling, and the ICG showing hypoperfused choroidal granulomatous region. So this is the fellow eye of the same patient. At first glance, the multimodal imaging appeared entirely normal. However, on the closer scrutiny details, I will be dealing in the next slides. So this patient was treated with IV methylprednisolone and for subsequently oral prednisolone tapering over 6 months with closer follow-up of the fellow eyes. and she had complete resolution of the serous retinal detachment. Visual acuity had improved. No recurrence of inflammation till date. So the fundus examination also you can see there is a complete resolution of the subretinal lesion and detachments. And this is the case 3, but quite young female, a 26-year-old, presenting with acute painless vision loss, isolated to the left eye, but her left eye visual acuity was 160, right eye was normal with a visual acuity of 66. And this is the picture, a huge multifocal subretinal detachment with OCT also showing the same. Enhanced depth imaging show a huge choroidal thickness, multiple subretinal loculated fluids, and unfortunately we don't have a ICG of this patient, but fundus fluorescein angiography showing pooling and multiple pinpoint leaks. This is the fellow eye which appears to be completely normal. And after immunosuppression therapy, even this patient responded very well back to 6/6 vision. So keeping this in mind, we had a series of 15 cases. Me and my mentor, Dr. Mahesh Gopalakrishnan, had presented this in the uveitis forum in the Uretina. But this has sparked an intense discussion, particularly around the viewpoint that unilateral VKH doesn't exist biologically. It merely escapes a clinical dictation temporarily. So what in its presentation may appear to be unilateral, the underlying pathophysiology can be bilateral, presenting a significant diagnostic challenge. So these are two different cases. So this diagnostic challenge, how can we tackle it? Only by clear scrutiny of the multimodeling imaging. So the two clinical cues can be the ICG angiography and the EDA, enhanced depth imaging of the SDOCT. So these are the two eyes, fellow eyes of the involved, the other eye of the patient, that is other eye of the Harada involved eye. So these patients had, on the clear scrutiny on the ICG, you can see multiple hypocyanescent lesions. It is better delineated in the black on white images. So in this eye, you can see it is very subtle. It is very difficult to delineate the hypocyanescent lesion, but the black on white images, you can clearly see this hypocyanescent lesion. And one more clue is the enhanced depth imaging. Even in the other eye, you can see that the choroidal thickness is large. These are the two representative images of the same. So the choroidal images being large, and even though clinically silent, the ICG is showing hypocyanescent spots. This is another patient, the involved eye and the uninvolved eye. If you see clearly or if you examine it clearly, you can still see this hypocyanescent multiple choroidal spots, which is clear even in this filters or on the black on white image, and the enhanced depth imaging showing the huge choroidal thickness. So one more thing that has aborted the disease process might be the early immunosuppression. That is, these patients might have presented to you early and you have aborted this disease process with early aggressive immunosuppression. So there are clinical benefits of timely aggressive intervention. It can also prevent the chronic evolution and recurrent inflammation. But the story is not yet over. Long-term monitoring is definitely needed for the confirmation. There are a lot of case reports like unilateral VKH has again evolved with recurrent episodes of inflammation. So coming to a conclusion, the VKH, the pathophysiological reality can be bilaterality, and early aggressive immunosuppression is paramount. So the key questions is like, if there is something like a unilateral VKH, or it is clearly a misnomer. Thank you, ma'am.
Thank you for that presentation. And it's a question that has been hanging around for a while. Like you said, I think you should not label VKH as, by definition it is bilateral. Even the Sun criteria says it is bilateral. So usually you may have one eye which is slightly worse than the other, but it's usually bilateral in presentation. So I don't think you should label something as VKH, without doing ICG. This is absolutely not negotiable. I think ICG is must before labeling something as unilateral VKH. And when you do ICG, you very often see that the other eye, there is involvement. The other thing, I want everybody to be cautious about is bacillary layer detachment is not unique to VKH. It's seen across a spectrum of disorders. And one of the other things, which people confuse with a unilateral, VKH is a multifocal choroiditis. And the way to differentiate the two clinically is that the MFC lesions, their size varies. Okay, the VKH lesions are kind of more uniform, and the distribution varies as well. So we don't see people doing a lot of V scan these days, but VKH is a pan choroiditis. It affects the entire choroid. So any quadrant you check, you should have an RCS thickening. Whereas the multifocal choroiditis, only that portion will show RCS thickening, and this is very important. Yeah.
Also, in case of unilateral such a presentation, what are the other conditions we should be thinking about?
Yeah, like I said, one is multifocal choroiditis. You need to rule out tuberculosis. Posterior scleritis. Yeah, you need to rule that out as well.
But in multifocal choroiditis, do you get that multifocal serous detachment, ma'am, in
You
OCT?
can, in some cases, yes.
Okay.
Yes.
And also in a unilateral VKH, I think the history of trauma should be ruled out because sympathetic ophthalmia is a very important condition to rule out. Thank you, Dr. Divya.
Thank you, ma'am.
So next we have Dr. Suchitra Bhatt, who is going to talk on sarcoidosis in a child, an interesting encounter. Dr. Suchitra Bhatt is a medical retina consultant at Ashoka Hospital, Kannur. Over to you.
Pointer. Good morning, everybody. I'm going to present a simple cases which I encountered in a child. So, offering my pranamas to my guru, teacher, mentor, late Dr. B.B. Bhatt, I'm going to start my presentation. Mine was a young teenage girl who presented to our OP last year, who is aged 14 years, who presented to us with floaters in right eye since 1 week. On examination, both eyes vision was 6/6, though the right eye was little blurred. Anterior segment was absolutely normal. Posterior segment showed dense vitreous hemorrhage. We couldn't make out any other details. So as we usually manage the vitreous hemorrhage, we asked her to rest for 1 week, give vitamin C tablets, and advised a propped up position. And 1 week follow, she showed clearing vitreous hemorrhage. Central fundus was still not clear, but periphery we could see, and we were expecting a tear hole. Nothing of that sort was there. So our diagnosis could not be complete. So we asked her to review after 3 weeks. Then after 3 weeks in April, she comes back now actually with diminished vision in the right eye, that is about 6/12. On examination, her vitreous hemorrhage was resolved, and we could see here, as shown, a clear-cut neovascularization superior to the disc and inferior to the disc, with the obvious clear-cut macular edema confirmed by the OCT that was responsible for her decrease in vision. So what do we do when we see a neovascularization? We do a FFA. So this is a FFA photograph showing initial minimal staining of the blood vessels. This is the periphery in the mid phase. I want you to see that there was no choroidal non-perfusion areas usually we see in any neovascularization. And this is a late phase showing clear-cut neovascularization and obvious macular edema. This is the left eye of the patient, which was absolutely normal. Since this is the summary of the FFA, we can see the clear-cut neovascularization, and in the last photograph, you can see the periphery with mild inflammation of the blood vessels and without absolutely non-perfusion areas, and the left eye was normal. So now we were thinking that we were dealing something with inflammation. So a diagnosis of posterior uveitis was made. So we came to know that it is an inflammatory neovascularization of the disc. So I went back and searched, and we found that inflammatory neovascular disc is seen in Behçet's or sarcoidosis. Since patient didn't have any features of Behçet's, we thought it might be sarcoidosis and went ahead with simple investigation, which is done in a basic hospital. So investigation, serum AC, MAN2, toxo, VDRL, everything was normal. CT chest was absolutely normal. I discussed with the pulmonologist, was there any lesion? He said it was absolutely normal. And routine blood investigations, everything was normal. So we started, since it was not infective cause of uveitis, we started her on oral steroids, 50 mg for 2 weeks with gradual taper. for every 1 week. There was still only partial response. The neovascular disc was still there. It was neither increasing nor decreasing. So we thought we'll add immunosuppressants. We started with 15 mg per week with folic acid, and after 1 month we maintained her with 10 mg per week. Treatment continued till October. That is from April to October. We are giving her the same treatment, checking her blood test, everything was normal. Same picture, NVD. So in November, now she comes back, actual picture of circumciliary congestion, scleral congestion, pain, grade 4 cells, flare, etc. And the disc showing still neovascularization of the disc. After this presentation, after 1 week after this, she developed the same vitreous hemorrhage, dense vitreous hemorrhage, which we saw in the beginning. So now it was a pan uveitis picture. Sclera was involved, anterior segment was involved, and posterior segment was involved. So we were like almost sure now we are dealing with sarcoidosis. So patient was sent to the rheumatologist since she was not responding very well both to the steroids and immunosuppressants. We asked her to start for biologics, and he started on subcutaneous adalimumab, which was given once in 2 weeks for 14 doses. Meanwhile, since we were scared she had recurrent vitreous hemorrhage, we did PRP in 2 to 3 sittings. Anti-inflammation was carried out, was taken care by topical steroids, and oral steroids was restarted, and now everything settled. Choroidal inflammation came down, AC became quiet, oral steroids now we tapered once the inflammation came down, and we maintained her on immunosuppressants till May 2025. Blood investigations were absolutely normal throughout the procedure. Lesions was completely healing. So this is a last follow-up in November 2025. You can see the neovascular disc is healed, but there is a lot of fibrosis there. So in case of inflammatory neovascularization, when it heals, there is a lot of fibrosis. And this is the inferior segment of the same, which we took. This is the last photograph in October. Now she is not under any treatment. So she is only on regular follow-up. So NVD, that is neovascularization of the disc, is reported in small percentage of cases, that is in 4% of in study of posterior uveitis patient. NVD in sarcoidosis is associated with intraocular inflammation and usually occurs in the context of posterior or panuveitis. The inflammation is due to release of pro-angiogenic factors that stimulate new vessel growth. Usually, sarcoidosis has a good visual outcome, but development of complications like this, NVD or optic neuritis, can lead to severe visual impairment if not treated. So, any patient, early ophthalmologic screening is recommended for all patients with a newly diagnosed sarcoidosis, even if they are asymptomatic, to monitor for complications like NVD. Inflammatory optic disc neovascularization is diagnosed in cases where FFA does not really reveal extensive retinal capillary non-perfusion, plus you have an evidence of intraocular inflammation. Primary therapy for inflammatory NVD is systemic steroids or immunosuppressants. Intravitreal anti-VEGFs can be an adjuvant therapy. So I just want to discuss here, should we have given intravitreal the earlier, or PRP was required, was it really required, or we were like over?
I don't think PRP was indicated because neovascularization in the background of uveitis can be driven either by inflammation or by non-perfusion. So you need to do imaging to assess what is driving it, or whether it's a combination of the two. If the inflammation is what is driving it, you need to control the inflammation. I think the best way would have been to give intravitreal Ozurdex, one shot. So
But since she was a girl, she's just a 14-year child, so cataract and glaucoma, we were little.
one shot, sometimes it does the trick. Ozurdex is sometimes like a bullet. It just takes care of it, while you are treating the rest of it systemically. I think what really helped us the adalimumab.
Yes.
That's what I think. If there is significant CNP areas, you can add PRP.
Yeah, there was no CNP.
Yeah, you have to control the inflammation. That applies to not just NVD and NV, it also applies to inflammatory CNVMs. If there is an active inflammation, you need to control the inflammation, otherwise it's going to come back. I have one question for you. Why did you think it is sarcoid?
That is what. Yeah, because it was a panuveitis picture. So panuveitis is usually caused by TB, sarcoidosis, syphilis, or other things. So since it was going more in favor of, and research showed that inflammatory neovascularization is seen mostly in sarcoidosis. That is why we made that diagnosis. She was not affording much for other investigations also.
Right.
So, that is
Right.
why we stopped, and she was responding to steroids and everything. And
Right.
rheumatologist also didn't ask for any other investigations. And in children, non-pulmonary manifestations are common. We searched for all those things also, and it was not there actually.
That is true. But having said that, if you look at the diagnostic criteria for ocular sarcoid, this patient doesn't fit into it. The management, is
Yeah, the same.
probably the same. It
So
doesn't make a difference.
I just want
Yeah.
madam's experience. What else in neovascularization? Which other disease you can expect here, ma'am?
In children,
Children or adults in neovascularization of the
Causes
disc
of
or
inflammatory NVD, ma'am. What are the
inflammatory
other
NVD.
diagnoses which you can?
and for that matter, any vasculitis, like I think it would be more common with, something like with the occlusive vasculitis, TB, SLE. Behçet's, in spite of being occlusive, doesn't seem to produce that much of neovascular. I don't know why. Yeah.
Thank you, Dr. Chitra. Suchitra.
With now, invite speaker Dr. Dalia Krishnan to present her talk, A Twist in the Tail. She's a medical retina consultant at Dr. Srikanth Eye Care Hospital, Kozhikode, and she's an expert at treating uveitis and macular pathologies. So over to you, Dalia ma'am.
Thank you, Dr. Divya. Thank you, Drishti organizing team, for giving me this opportunity. So let's start the twist and the tails. So the case number 1, 63-year-old female patient came with blurring of vision in both eyes of 3 months duration. On examination, visions were 624 and 2/60, and anterior segment showed medium and large size mutton fat KPs in both eyes with severe AC reaction and plenty of cells in the anterior vitreous with cataract. So fundus examination, the media was very hazy due to numerous large vitreous opacities, and very hazily we could see multifocal retinal or subretinal yellowish white lesions in the fundus in both eyes. So we had a provisional diagnosis of bilateral granulomatous panuveitis. So the things which we were in our mind were sarcoidosis, tuberculosis, masquerade, of course. So blood tests were sent, and she was started on topical steroids with cycloplegics. So serum A's came positive, and peripheral smear showed eosinophilia. So we took a chest opinion, but there was no evidence of tuberculosis or sarcoidosis. So on follow-up of 1 week after topical steroids, the AC reaction had reduced, and we could see plenty of large white cells in the anterior vitreous. So now the posterior segment were also slightly more visible. We could see the vitreous floaters. There were some subretinal drosenoid deposits seen in the macula in both eyes, which is more in the left eye. And the multifocal subretinal cream-colored lesions were also visible more. So we did an OCT, which showed in the left eye multiple irregular RP elevations with sub-RP deposits seen in the macula. So this is suspicious. So this was the first twist. So our differential diagnosis changed. So now we were thinking of primary vitreoretinal lymphoma as the first DD. So we ordered MRI brain with orbit to rule out CNS lymphoma. The report came negative with just bulky lacrimal glands. And in fact, they put a comment that there's a remote possibility of lymphoproliferative disease. So we advised for a diagnostic vitrectomy, but the patient was not willing of the MRI report. So we took an orbit opinion, but the lacrimal gland was not palpable. So even that risk was explained and the patient was not willing. So the patient came for follow-up after 4 weeks as it was not willing. Again, now the multifocal lesions had increased in size. Especially in the left eye, we could see large lesions temporal to the macula. The OCT, the sub-RP deposits had increased and become more extensive. So now there was an urgent need for a definitive diagnosis. So we discussed and convinced, showed all the scans, and the bystanders were convinced regarding the need of diagnostic vitrectomy. We also advised them a second opinion with Dr. Prakash at Combrist, and he did a diagnostic vitrectomy with chorioretinal biopsy. And here came the real twist in the tail. So the cytology report came positive for B-cell lymphoma. So now our diagnosis is bilateral primary vitreoretinal lymphoma without CNS involvement. So oncologist opinion was taken, advised systemic treatment. Patient was not willing because did not So intravitreal therapy was started with rituximab in both the eyes. Or 2 months follow-up, the AC reaction had reduced in both eyes. We could see medium large pigmented KPs, and fundus view, the subretinal lesions had reduced a bit. But within 3 months, the patient was admitted in the hospital with altered sensorium, confirmed to have CNS lymphoma. Systemic chemotherapy was started, but she expired in 6 months. So let's not end the tale in a sad note. Coming to the case number 2, a 62-year-old male who consulted me on July 2025 with the complaints of increase in floaters in the last 3 months. So on ocular examination, it was a bilateral Fuchs-like presentation, diffuse stellate medium-sized KPs, and anterior vitreous had plenty of large white cells. So bilateral Fuchs is a rarity. So here itself the red flags came. So fundus examination, almost similar picture. Media hazy due to large vitreous opacities. It was a dull foveal reflex with few drusenoid deposits. So if you could see clearly, there was this drusenoid deposits in the perifoveal region, more visible in the left eye. So OCT macula was done, which showed RP thickening with nodularity, with changes in the ellipsoid layer. Fundus fluorescent angiography showed some stipple fluorescence in the perifoveal region. So here we had a bilateral granulomatous panuveitis with nuclear cataract in a 63-year-old with subretinal deposits, could be RP inflammatory changes. So our first DD was PVRL, but we wanted to rule out syphilis, sarcoid and TB. So the blood test was sent. IGRA came positive. So again, chest opinion was taken and TB ruled out. MRI brain with orbit was done to rule out CNS lymphoma. And here the patient was willing for diagnostic vitrectomy, and it was done to rule out. And the vitrectomy sample was sent for cytology, which came as non-Hodgkin's lymphoma. The flow cytometry and the immunophenotyping confirmed CD5 negative, CD10 negative, B chronic lymphoproliferative disorder. So again, the diagnosis is bilateral primary vitreoretinal lymphoma without the CNS involvement. So the oncologist opinion was taken and started chemotherapy according to the De-Angelis protocol with rituximab, methotrexate, vincristine and procarbazine, and intrathecal methotrexate. Intravitreal therapy was given with intravitreal injection of rituximab and methotrexate weekly once in the first month, 2 weekly once in the second month, and the third month intravitreal methotrexate 2 weekly, and the fourth month onwards monthly injection of intravitreal methotrexate. So post intravitreal injections and the chemotherapy, there is significant improvement in vitritis. The subretinal lesions are resolving, and the patient is going to have 9 months of intravitreal treatment. And also they are planning for a bone marrow transplantation for this patient. So on review of literature, primary vitreoretinal lymphoma is a very rare high-grade malignancy of B-cell origin with a poor prognosis, and it's a subtype of primary CNS lymphoma. Up to 90% of patients with PVRL eventually develop CNS involvement. So that's important. And also 50 to 25% with primary CNS lymphoma go on to develop ocular dissemination of the disease. So when I review the literature, this particular study from Marchesi et al. About the anterior segment involvement in biopsy-proven vitreoretinal lymphoma, they said that 51% of patients present with anterior segment involvement and different types of KPs, dendritiform with branching and irregular margins as seen in the second case, and large granulomatous as seen in our first case, and also dust-like KPs can be seen. Also, the OCT images of biopsy-proven was studied by Barry et al., which showed multiple OCT features of PVRL, but the hyperreflective subretinal infiltrates give a unique appearance of PVRL. So my take-home points are, you should have a high index of suspicion to identify PVRL in a timely manner, may present with anterior segment inflammation with different types of KPs and AC cells. The vitreous cells are typically large and white. OCT is critical in the early detection of subretinal deposits and guide indication for tissue diagnosis. The gold standard for diagnosis is intraocular cytological examination, which is obtained by vitrectomy and chororetinal biopsy. A multi-team approach is required in the management of PVRL with the collaboration between the ophthalmologist, the oncologist, cytopathologist, and neurologist to optimize the patient's regimen. So my queries to Madam is, in this particular case, the second case, actually the vitreous sample was sent to 2 places. In one of the lab, it came negative, and from other lab, it came positive. So in such cases, if when you're suspecting PVRL clinically, if the vitreous specimen cytology comes negative, what should be the next step?
Repeat the biopsy.
Okay.
If somebody has actually started steroids, you need to do a rapid taper and stop it, at least for 2 weeks, because use of steroids, reduces the positivity of the sample. Yeah, but if your clinical suspicion is very strong, I would say repeat it, because everybody says this, sometimes you need repeated sampling, to prove the diagnosis. The problem with intraocular lymphoma is that, it might show a partial response to steroid because it's toxic to the lymphocyte. And then, you have lost the time. Yeah.
Thank you, ma'am.
You want
Ma'am, in your experience with PVRL, if you can share.
Oh, yeah. So, um, the two most common patterns you're going to see with PVRL is, it can be confused with intermediate uveitis, so it might present with just vitritis, or it can present with the subretinal deposits, which in certain cases can be really, really large. And on clinical examination, you might think it is a choroidal lesion. And there's some of the myths you have already talked about, that you think lymphoma will not present with keratic precipitate and cells in the AC, and that is not true. And the second myth is that it can regress spontaneously, leaving scars. Okay, so it can do that because your immune system does fight against the tumors as well. With the vitritis, what you normally see is the sheets of cells, coming in from the periphery. And in spite of the media being very hazy, their vision will be relatively better than what you anticipate. The subretinal lesions have a very classic appearance. You have this leopard's skin spotting. Okay. And that is very typical of intraocular lymphoma. If you have seen it once, you'll never forget it. And I think that the imaging modality which is best for picking up intraocular lymphoma is OCT. And even if the media is hazy, you should attempt to get an OCT through, if there is a lesion, try to get it through the lesion, not the very large lesion, get the smaller lesions. The large lesions will cause shadowing, and it's difficult to gauge it. The smaller lesion will tell you that it is exactly that subbar PE deficit. So it's subbar PE deficits or retinal infiltrates. And cystoid macular edema is usually not present in, yeah.
Thank you, ma'am.
Thank you, Dr. Dahlia, ma'am, for that excellent talk. With that, I now invite Dr. Femina N. Hashim for her talk on the puzzle of retinal vasculitis. She is a consultant at Chaitanya Eye Hospital, Trivandrum, Kerala, and her special interest is in the field of uvea and ocular inflammation. Over to you, Dr. Femina.
A very warm good morning to one and all. Today I will be discussing a young patient, 46-year-old lady without any systemic comorbidities, presented with our OP in complaints of flutters in the left eye for around 3 weeks duration. There was no specific systemic history or any uveitic history. Her best corrected visual acuity was 6/6 both eyes, and anterior segment there was no evidence of inflammation, except in the anterior vitreous phase there was few pigmented cells. So once we dilated, this was the fundus examination. You can see in the right eye there was neovascularization of the disc, and in the left eye there was no NVD, but whereas neovascularization of elsewhere was present with pre-retinal hemorrhages and settled hemorrhages. In both eye was showing peripheral sheathing or occlusive vasculitis. So under this diagnosis, we just did an uveitis and the vasculitis workup, but all investigations came negative, including the TB, sarcoidosis, and all other vasculitis. So we did an angiogram for this patient, and this is the angiogram picture, and you can clearly see how extensive is the gross peripheral ischemia. And there was in the right eye there was profuse disc leakage and mild perifoveal leakage, as well as the NVE was leaking with vasculitis and the peripheral shunting of the vessels. And the most importantly, there was gross peripheral ischemia. And this was the left eye picture. It was also showing the extensive peripheral ischemia or the capillary non-perfusion areas. So considering this extensive capillary non-perfusion, we have to do a diagnosis, but all other investigations came as negative. So we just revisited the case once again. So this was what we have found once you revisit the case. And in the right eye, the both eyes, you can see some beaded appearance of the vessels, which is not typical in usual cases. So, but we are not convinced with this beaded appearance of the vessels because these were not leaking in the angiogram. So this was the most turning point in our case, that is the beaded or the tied node appearance of the vessels. So, coming to the summary, we have a case of bilateral occlusive vasculitis. It's a female patient in a young age, mainly having a beaded appearance of the vessels. And in the angiogram, you have some neuroretinitis-like features like disc leakage and macular leakage without any systemic workup positivity. So, we just differentially diagnosed it as a case of idiopathic retinal vasculitis, aneurysms, and neuroretinitis because none other diagnosis was fit into our protocols. So we just diagnosed it as a IRVAN, and we just started with the oral steroids for this patient because in IRVAN most of the time the inflammation is the integral part. So we just started in an oral steroid along with considering the extensive capillary non-perfusion areas. We have just started with the peripheral PRP 3 sittings for both eyes. So this was the follow-up visit of the patient. Once the vision was absolutely normal, 6/6 in the initial visit also. So once we following the patient, there was the NV was regressing, NVD was regressing, and the vision was stable without the systemic improvement also. So, idiopathic retinal vasculitis, aneurysms, and neuroretinitis is a rare clinical entity of unknown etiology, typically affects young, healthy individuals, and has a female preponderance without any systemic association. And these are the most common stages. The stage 1, there will be macroaneurysms, exudation, neuroretinitis, retinal vasculitis. And in the second stage, there will be capillary non-perfusion, mainly in the angiographic evidence. And the third stage, there is posterior segment neovascularization of the disc or elsewhere and or vitreous hemorrhage. And the fourth stage, you will have an anterior segment neovascularization or rubeosis iridis. And fifth stage is neovascular glaucoma. So it's important to rule out other causes of vasculitis like a TB and other type of SLE, all these cases. And PRP to the extensive CNP and the neovascularization, and early laser has a better visual prognosis, and laser to the macroaneurysms may result in occlusion. Intravitreal anti-VEGF can be indicated for the macular edema, vitreous hemorrhage, or neovascularization. So my question to ma'am is, in these type of cases usually we encounter in OP where we don't have a definite diagnosis. Most of the investigations will be negative, but considering the high amount of peripheral non-perfusion areas, do we need an extensive treatment or any immunosuppressive therapy for these type of patients?
Okay. So the thing is, the IRWAN's prognosis, can vary from person to person. So if you look in the literature, there's cases of spontaneous regression of the aneurysms as well. So whether they need immunosuppressive therapy depends on whether they have active inflammation. And I would kind of use the FFA to guide it. If there is active inflammation, I would start treating them with oral steroids. And some of them might just need oral steroids. If that it's not working, you add a antimetabolite, conventional antimetabolite. But we have a couple of patients who have actually needed biologicals, injection adalimumab. So with really good results, So it depends on whether there is an active inflammation which is not controlled. So not all cases need conventional immunosuppressive therapy. And if there's no active inflammation, you don't need to treat it with immunosuppression.
Ma'am, in these type of cases, there won't be any active inflammation except all the peripheral occlusive vasculitis. Definitely, we should start the peripheral PRP. But is there any role of steroids in the initial visit for these type of patients? This patient we just randomly diagnosed as an IRVAN, but in most of the cases we couldn't find a diagnosis. But most of the investigations will be negative. So we will.
Yeah, so vasculitis is an integral part of, it's a major diagnostic criteria. By that you mean you actually see vasculitis, you see vascular leakage. Your case may not have had it, but a lot of the IRWAN patients will have vasculitis. And that's one of the features which distinguishes IRWAN from other causes of aneurysms. Okay, there are other conditions, which can cause retinal aneurysm, but the vasculitis, is peculiar to IRWAN. So your case may not have had an active vasculitis, but most of them do. And there's a major criteria and a minor criteria. Yeah. What was the other question?
No, ma'am, not about this IRWAN. If there is a peripheral occlusive vasculitis we couldn't find any diagnosis, in that cases, do we really need a steroid or PRP will be suffice?
Sometimes, if you think it's an inflammatory occlusive vasculitis, and you're going to laser very extensive areas, I like to give short steroid cover so that there's no flare up. That you're not actually treating an active inflammation. You're trying to prevent it. Something like giving a preoperative steroid cover before cataract surgery. Yeah,
Thank you.
do that.
Thank you, Dr. Femina. So next, ma'am. Next, we have the keynote address by Dr. Anuradha VK. She's the head of the UVA department at Eye Hospital, Coimbatore, and she's a co-investigator, a principal investigator in multiple studies, and she has various publications in both national and international journals. So she's going to speak. When you hear hoofbeats, think horses, but don't forget the zebra. What do you, ma'am?
Thank you, Dalia, and the organizers of Drishti for asking me to be part of this program. So this is something, which has been hammered into our head, as doctors, that when you hear hoofbeats, think horses, So what is most probable, most likely is, going to be your diagnosis. But unfortunately, diseases don't read textbooks. And uveitis is one of those specialities, where you can throw a curveball at you, every now and then. So I'm going to share 7 cases, which I've seen during my career and, tell you what I've learned from it. So my first patient was a 23-year-old seminary student, already diagnosed with Behçet's and on methotrexate. And he actually moved from Aravind Madurai to Aravind Coimbatore. Because at that time, his left eye had already lost some vision due to macular scarring. Right eye was his seeing eye with 6/6 vision. Because he was not adequately controlled on methotrexate, this is in 2013, I put him on cyclophosphamide. And for a while, he was doing well. And then, because of concern for a respiratory infection, I stopped the cyclophosphamide. And after talking to the pulmonologist, just bumped up the omnacortil to around 25 milligram 30. And then one day he comes with a sudden drop in vision in the right eye. It went from 6/6 to 5/60 overnight. Okay. Now, although it's not very obvious, there's a significant vitritis. Inferiorly, there were a lot of pre-retinal exudates. You can see the hemorrhages with the retinitis or retinal infiltrates. Now, because this patient was already immunosuppressed, had a respiratory infection, I was very concerned about an opportunistic infection in this case. So we took him for a vitreous biopsy, sent the sample for PCR and smear and culture, both for bacteria, fungus, virus, and toxo. All of them came out to be negative. So we put him on IV methylprednisolone, not for the usual 3 days, but for 5 days. And then I referred him to rheumatologist for biologicals. Initially put on infliximab and then on adalimumab. He actually did very well. He responded to the treatment. And he was kept on triple immunosuppression with azathioprine, cyclosporin, and low-dose steroid for a long time, but he has come off the steroid now. And this is him about 10 years later. You can see he's maintaining 6/9 vision in the right eye. Left eye is around 6/24. So Behçet's is a very unique disease in that, and it's not uncommon in our part of the world, particularly in Kerala. It's a non-infectious uveitis which is capable of mimicking a spectrum of infectious uveitis. So it can present with hyperpion and retinal, pre-retinal exudates mimicking an end-off. the retinal infiltrates in Behçet's can be mistaken for toxoplasma. And I've even seen a case, which presented with what looked like a subretinal abscess. So you need to keep that in mind. Our second patient is a 34-year-old lady who referred as left eye intermediate uveitis with pain, redness, and decrease in vision. There was 2+ cells and DM folds in the cornea. And you can see in the fundus photo there is significant vitritis, vitreous opacity. There was no focal lesions visible in the fundus. There was no vasculitis, retinitis, or choroiditis. My colleague, who was smart enough to look at the anterior vitreous space, however, picked up this. You can see that it's a very active motile worm in the anterior vitreous space. So the patient was taken up for vitrectomy, during which process the worm was eaten up and then treated with a combination of albendazole because we couldn't identify the worm. It treated with a combination of albendazole and steroids and did very well. This is another case, and this kind of a picture might be more familiar to you, but it is still a relatively underdiagnosed condition. It is DUSN. As a 40-year-old male presenting with decreased vision, pain, and redness in the left eye, referred as multifocal choroiditis. So that's what usually happens with Duchenne, it's referred as multifocal choroiditis. And you have this multiple lesions, which are subretinal. And what is characteristic about it is a clustering. So, and the lesions are in different stage of healing. So the lesions here, they have healed, and these yellow lesions here, they are active. You can also see the tracks here. Okay, you don't see tracks in all cases, but when you see this lesions, very small lesions in varied stages of healing and clustering, you should think about Duchenne. And if you have an OCT, do run it through the active lesion. These lesions are not in the choroid, they are in the outer retina. So in this case, there is a live worm there subretinally. I hope you can see it. Yeah. So the patient was treated with laser to the worm and combination of albendazole and steroid and recovered 6/6 vision. Now, parasitic infections causing inflammation, it's a difficult to pick up, for multiple reasons. One is that other than Duchenne, they may not present with a specific pattern, so it might look like intermediate uveitis or anterior uveitis. And the worm, is very difficult to locate. You may not always find the worm. But it's important that you do gonio, important that you check the anterior vitreous space and do a thorough examination of the fundus. I find that, looking, where the active lesions are, you have better chances of picking it up. Yeah. Our fourth patient is a 48-year-old female on HART since 2007. And she's also undergone surgery for Regardie in the right eye in May 2007. So she was coming in for a routine follow-up. Right fundus is not visible because of a very thick PCO. And the doctor who examined her in retina, happened to note the choroidal folds and a subretinal pocket of fluid around the disc. So it was referred to UVA department, and the OCT confirms the presence of SRF, choroidal thickening, and the RP undulation. And a B scan of both eyes shows RCS thickening in both eyes with exudative VADI in the right eye. FFA shows the typical pinpoint leaks with late pooling here. So a clinical diagnosis was, all the baselines were negative, Manto, TPHA, everything else was negative. The CT chest the chest X-ray was normal. So we came to the conclusion of sympathetic ophthalmia, secondary to VR surgery in the right eye. So after clearance from the ART physician, who assessed her CD4 count, did a viral load which was undetectable, she was cleared for high-dose oral steroids with methotrexate. And this is the response to the treatment. You can see the reduction in the RCS thickening and the resolution of exudative VADI. So when you think of uveitis in HIV patients, you think opportunistic infections or a masquerade, which is, is a correct thing to do. But, do not think that, these patients cannot develop an autoimmune disease. It is known to happen. There are other reports of VKH in HIV patients. The other thing which you should not do is, just because it's a HIV patient, you should not think that you can treat it locally or ignore the protocol. Something like sympathetic ophthalmia is indication for primary immunosuppression, and you have to get in touch with the treating physician, have a good talk with the patient, and follow the protocols. Case 5 is a 30-year-old male patient known to be an open case of pulmonary TB, sputum positive on ATT for 2 months, now complaining of pain, redness, and decreased vision in the left eye. And by the time he came to us, the left eye had neovascular glaucoma with IOP of 44. The vision was down to PR inaccurate. And the media was very hazy, and through the haze, we could see a yellowish mass at the back of the eye, confirmed on B scan. You can see here dome-shaped mass with variable internal reflectivity and exudative retinal detachment. So this was thought to be more fitting with a granuloma. He was HIV negative, so we put 2 and 2 together. You have a yellowish mass, happening in a patient who was on treatment for pulmonary TB. So after clearance, we started him on oral steroids under cover of ATT, of course. The first couple of visits, he was okay. 2 months after initiating steroids, and when we started tapering it, he comes in with extra scleral extension of the choroidal mass, and you can see that here in the ultrasound as well. Now we were very worried. We knew he was compliant to treatment. We knew drug resistance was unlikely because the pulmonary lesions had resolved and the sputum had turned negative. So then we thought, we have landed in hot water, missing a tumor, either a primary or secondary tumor. So we went ahead with a systemic evaluation. There was no sign of metastasis anywhere, but the CT of the eye and the brain confirmed the presence of the mass lesion extending minimally into medial rectus, optic disc, and proximal optic nerve, and the diagnosis was likely to be malignancy. So we went ahead with enucleation of the left eye and sent it for histopathology. I can tell you how much of relief I felt, no signs of malignancy. And this one turned out to be an intraocular granuloma here, breaking through into sclera, into the orbit. And although they could not see the organism in the histopathology, the tissue PCR turned out to be positive for TB and negative for fungus. Now, ocular TB can have paradoxical worsening, and this is a case of extreme paradoxical worsening in this case. So, Dr. Dalia was talking about primary vitreoretinal lymphoma, which is the most common malignancy, which can mimic a uveitis. And then somebody who's practicing, uveitis, we're always worried about, missing a malignancy. And I have to say that over the last 10 years, I feel that awareness has spread among people, and more people are, recognizing PVRL, even when it presents like uveitis, and that's a very, very welcome change. So this is our 6th case, a 41-year-old lady who was 36 weeks pregnant at the time of presentation, coming with decreased vision in the right eye for 4 weeks. She didn't have pain, but there was a temporal scleral congestion. So when you looked into her fundus, what was striking is this large clump of subretinal exudates. And you can see that here along with the exudative vadi. And then there was this smaller orange yellowish mass in the supratemporal quadrant, which on B scan showed moderate reflectivity and minimal amount of subtenon fluid. So with subretinal exudation and subtenon fluid, scleral congestion, we were thinking more in terms of an infection or an inflammation. So she was taken up for right vitreous biopsy with and given intravitreal antibiotics. The sample was sent out for PCR and end of panel testing for bacteria, fungus, and tuberculosis. All came out to be negative. After that, the patient chose to follow up locally, but we were in touch with the local ophthalmologist. And they told us that, she's not responding. And I think the Manto was borderline positive. So we decided to start her on ATT and oral steroids. Even with that, she kept worsening. Finally, after she delivered, she underwent a full workup, and it turned out to be a moderately differentiated adenocarcinoma of breast, which had metastasized to all parts of the body, including the eye. So we don't expect, metastasis to present with such florid inflammation, and certainly, I've seen cases where there is vitreous cells, AC cells, but I've never seen this kind of a subretinal exudate in a metastasis before or since. So some of the lessons I've learned from this is that, we should have actually checked for cervical lymphadenopathy. That's something we missed. And secondly, we did not do a chest imaging, because she was pregnant. But actually, if indicated, it should not prevent you from imaging the chest. It is perfectly fine to do it. In chest X-ray, CT scan, it is perfectly fine. And last patient is a 65-year-old male coming with defective vision, both eyes for 20 days. And when you look, both eyes have this very ill-defined yellowish subretinal lesions here, multiple lesions, which on OCT, in addition to the subretinal fluid, what is very striking is this thickened hyperreflective retinal pigment epithelium, which is, kind of absent in some areas here and here. And there is a layer of subretinal hyperreflective material as well. So this picture, didn't fit into anything which I knew at that time. So we're just thinking atypical CSR, atypical VKH, syphilis. Okay. So the autofluorescence, can I take? The autofluorescence showed a confluent hyperautofluorescence corresponding to the hyperreflective RPE, and the discrete hypofluorescence corresponds to the gaps in the RPE, and the FFA is a mirror image of the autofluorescence. His baseline blood tests were all normal. Even ESR, for somebody of his age would be considered normal. So finally we thought, after doing literature research, we thought idiopathic polymorphous vitelliform dystrophy. And we called him back after 10 days, after the initial consultation, and the SRF started resolving spontaneously, much to our joy, and that was the same in both eyes. And then we asked him to come back after 2 weeks, and the SRF is back. So same thing happening in the left eye, went back and went into more details into history. He said he has loss of weight and altered bowel habits. He was referred to oncologists who diagnosed carcinoma colon with widespread metastasis. So this is acute exudative paraneoplastic polymorphous vitelliform maculopathy. So my take-home points are, you should never try to slot a square peg into a round hole. By that, what I mean is, when you look at an eye and, you're thinking, it's neither this nor that, don't come to a presumptive diagnosis and start presumptive treatment. Go back to the history, reinvestigate if necessary, or get a second opinion. Second is, whenever I have tried to override my gut instinct with my brilliant logical thinking, I've always landed in trouble. So if your gut instinct is telling you, there's something wrong, this is not working, listen to it. And third is, it's very important for you to be honest with the patient. It's not like, you're the treating doctor, so therefore, you always have to give them a definitive diagnosis. You can tell them that, I've looked at you and these are the possibilities I see, and this is my plan A, and this is my plan B, and this is my plan C. If the patient sticks with you, well and fine, otherwise, it's very unlikely that they will come back at you, later saying, you screwed up my eyes. And lastly, learn from mistakes, either from yours or even better, from others. Thank you so much for your patient listening.
Thank you, ma'am, for those very useful practical tips. What you said in the giving possibilities to the patient is, I think that's the most important thing, because then you earn the patient's trust also. Because they also know that if we cannot make a definite diagnosis in such a difficult case, and then they have a good follow up. They come for a closer follow up. They're ready for that. So that's a very useful tip. Just one question: in Dusan, what is the dose of albendazole which you gave?
400 milligrams.
How many days? They're saying for 30 days now?
I don't
Yeah,
know.
it's for 30
4
days.
weeks, yeah.
Yeah, so that's, thank you, ma'am. So I think we have run short of time. Any queries from the audience? So I think we'll wind up the session. Thank you so much, ma'am. Thank you all my speakers, Dr. Suchitra, Dr. Femina, Dr. Divya.